Professor Sir and Professor Varsini Madam and my dear students, I welcome you all to another session of Railway Anesthesia DNB online academic activities on this platform. Today we have important sessions on clinical as well as theory related questions and answers. Without wasting much of your time, I hand over the session to Dr. Venkateshwara Rao to go ahead with his first presentation of the case scenario. Question.
Sir, good evening, sir.
Good evening.
Today my topic is 5 days old neonate posted for Ramstedt procedure. Discuss anesthetic management. Coming to the introduction, infantile pyloric stenosis is the result of hypertrophy of smooth muscles of pylorus causing gastric outlet obstruction. The risk of disease is 4 to 5 times higher in boys than girls, more common in monozygotic twins, and the use of macrolide antibiotics such as erythromycin during perinatal period may also increase the risk of occurrence. Babies with infantile pyloric stenosis present most commonly in second and third month of life, though the babies can also be presented early within the month. They present with history of projectile vomiting of non-bilious stomach contents, dehydration with sunken eyes and fontanelle. Examination may reveal a palpable olive swelling in upper abdomen, best visible immediately after a bout of vomiting. Conrad Ramstedt in 1912 described a surgical approach to the management of pyloric stenosis, which involves longitudinal incision through the muscles of pylorus through to but not perforating the mucosa. Later on, a laparoscopic approach is described by Allen and colleagues in 1991. Coming to the anesthetic concerns. First is neonatal anesthesia. Neonatal anesthesia requires a unique knowledge of neonatal physiology, which is different from older infants, children, and adults. Oftentimes, the health professionals have limited experience caring for neonate or neonatal anesthesia, which can be stressful for the practitioners. Some of the issues of concerns in neonatal anesthesia are: first, thermoregulation in neonates. Neonates are more susceptible to hypothermia because of decreased bone fat, increased body surface area exposed, and GA per se inhibits central thermoregulations. Second is glucose management. Neonates and preterm infants are at risk of hypoglycemia due to impaired glycogenolysis and gluconeogenesis. Term neonates may require 3 to 5 mg per kg per minute of glucose, and preterm neonate may require 5 to 6 mg per kg per minute. Third thing is positioning technical difficulties, especially IV cannulations and accidental extubations, and intubations and airway management. Because of large head, tongue, floppy epiglottis, and more cephaloid position of larynx, these neonates are candidates for difficult in intubations. And also neonates are known to desaturate quickly because of closing pressure of neonates airway is very low and occurs very quickly with the loss of ventilation. Moreover, neonatal oxygen consumption is high, around 6 ml per kg per minute versus 3 ml per kg per minute for an adult. Coming to the anesthetic concerns regarding disease process, such as dehydration, hypokalemic, hyponatremic, hypochloremic metabolic alkalosis. As vomiting is the principal symptom, which is predominantly contains gastric secretions which are rich in hydrogen chloride ions with sodium and potassium, all of which will be lost along with water. Due to dehydration, there is increased aldosterone secretion, which in turn causes increased potassium loss, resulting in hypokalemic, hyponatremic metabolic alkalosis. And bicarbonate may also be lost by the kidney. Because of metabolic alkalosis seen in many babies with pyloric stenosis, the CSF pressure may be increased, causing a reduction in respiratory drive, which is not corrected even after correction of alkalosis for a period of 12 to 48 hours. This in conjugation with respiratory drive that may not fully mature until 44 weeks post conceptual age may place even full-term infants undergoing pyloromyotomy at risk for post-anesthetic apnea. Thus, these babies should be monitored for at least 12 to 24 hours after anesthesia for post-operative apnea. And next important concern is This baby should be treated as full stomach with concerns regarding pulmonary aspiration and of gastric contents. Coming to anesthetic management. First, preoperative assessment and preparation. Correction of dehydration and metabolic and electrolyte abnormalities. Pyloric stenosis is a medical emergency, not a surgical emergency. Hence, the baby should be assessed for signs of dehydration like lethargy, poor skin turgor, sunken eyes, and fontanelle, poor urine output, and any metabolic derailment, especially hypokalemia and metabolic alkalosis, should be corrected before taking up for surgeries. Bolus fluid administration at the rate of 10 to 20 ml per kg of 5% dextrose plus half normal saline with potassium chloride 1 to 2 milliequivalents per kg per day can be added. The preparation may require 12 to 74 hours depending on the severity of presentation. Though the present given clinical scenario, the baby is 5 days old who may or may not present with symptoms and signs of metabolic derangement. However, it is better to assess and treat before taking up for procedure. In preoperative assessment, look for other congenital anomalies, especially congenital heart disease. Coming to the role of nasogastric tube preoperatively. Previously, NG tubes were inserted routinely as a part of medical management sometime before arrival in the operating room. It has been proposed that constant drainage of gastric secretions worsens the electrolyte imbalance, and in the absence of milk feed, it is unnecessary in the preoperative period. Consequently, it is better to put NG or orogastric tube and aspirate the gastric contents just prior to induction. What is the role of ultrasound in assessment of gastric contents? With the invention of USG, barium's value are not routinely done to diagnose pulmonary stenosis. Ultrasound is useful to assess the gastric volume contents quickly and easily before induction of anesthesia. Place the infant in right lateral decubitus position and scan the stomach for any contents. Assessing in supine position usually reveals nothing but air artifact. So it is better to scan the baby in right lateral decubitus position. Preoperative advice. Informed risk consent obtained from the parents, nil by mouth, IV fluids depending on the severity of dehydration and correction of metabolic and electrolyte derangement, usually 150 ml per kg per day. And choice of anesthesia is general anesthesia with endotracheal intubation with modified rapid sequence induction. Coming to the intraoperative preparation and anesthetic management. Anesthetic induction, maintenance, and recovery in neonates can be challenging, requiring proper planning and execution. Senior member of the faculty who had experience in neonatal anesthesia will be attended to provide the anesthesia. Coming to the checklist. Before shifting the baby to OR, make sure that all necessary equipment is available, such as properly functioning workstation with pediatric circuit, the Jackson-Rees modification of ISTPs, face masks such as Renden-Baker-Sosik face mask 011, laryngoscope blades, Miller state blade 011, and McIntosh blades, depending on the anesthetic choices, appropriate size ET tubes 3 and 2.5, and suction catheter and properly working suction apparatus, and well prepared drug chart based on baby weight and availability of all emergency drugs. Second thing is methods to prevent heat loss in neonate. Better to warm the OR operation theater before baby arrival. You can use underwater forced air warmers or warming lights. Hats can also be used to prevent heat loss. All IV fluids and all the fluids on surgical field should be warmed. Coming to the IV fluids and IV cannulation. Before inducing, check for properly functioning IV cannulas. If the IV access is not available, umbilical vessels can be used. Prepare a pediatric burette set, and the choice of fluid is 5% dextrose with 0.5% NS. Some studies say in first hour start with 10% dextrose with water, followed by second hour 10% dextrose with half NS. Whatever the fluid is administered, hypoglycemia should be prevented by giving glucose at the rate of 5 mg per kg per minute. Fluid should be calculated and better to administered through infusion pumps. Coming to monitoring, it includes pediatric pulse oximetry, ECG, precordial stethoscope, ETCO2, temperature monitoring, and urine output. Coming to position and draping, make sure that neonate is properly positioned and accessible for immediate intervention, especially ET tube and IV cannula disconnections. Proper fixation of IV cannula and ET tube and connectors is mandatory. Before induction, stomach should be emptied by placing a NG tube, usual 6 size, and aspiration of gastric contents. Recent advance, that is utility of ultrasound, can be useful to assess the gastric contents. So to decrease the pulmonary aspiration, smooth induction and intubation should be done after complete neuromuscular blockade. Pre-medication. Antisolagogue in the form of glycopyrrolate and atropine at the dose of 10 mic per kg can be administered. So classical rapid sequence induction and intubation as performed in adults with required pressure and no bag mask ventilation should not be applied, as neonate airway is easy, compressible and deformed with external pressure. Moreover, it is difficult to identify the cricoid cartilage. FRC also, functional residual capacity also, is decreased when compared to older children because of increased chest wall elasticity, splinting of diaphragm by their comparatively large abdomen, and increased oxygen consumption around 6 ml per kg per minute. All these factors makes the onset of hypoxemia more rapid with no bag and mask ventilation. So modified RSI, which means gentle face mask ventilation, is required. Choice of induction. It depends on the choice of anesthetist. It can be tried with inhalational with sevoflurane 4 to 6% and oxygen and medical air, or IV propofol 3 mg per kg or ketamine 2 mg per kg. And fresh gas flow rate should be 2 to 3 times the minute ventilation. A good face mask seal and patent upper airway are confirmed by movement of reservoir bag as the neonate breathes spontaneously. A small folded towel can be placed underneath the shoulder to obtain a neutral position of head and neck, which aids in intubation. Relaxant is choline 2 mg per kg with gentle face mask ventilation and intubate with uncuffed ET tube 3 after complete neuromuscular blockade. Tube is fixed after bilateral confirmation of air entry. And make sure that ET tube plasters are properly secured to prevent accidental extubation. Ventilation strategies. Tidal volume 4 to 6 ml per kg and a rate around 30 to 40 per minute. Maintain with oxygen, air, sevoflurane and atracurium. Avoid nitrous oxide to prevent expansion of bowel gases. Coming to opioids. Short-acting opioids in the form of fentanyl can be given, but cautious of postoperative apnea as these babies are very prone. So coming to analgesia. So ultrasound-guided rectal sheath block, tab block, local infiltration, or systemic analgesia in the form of rectal paracetamol suppository at the dose of 20 to 30 mg per kg can be given. Towards the end of the procedure, the surgeons may ask to inflate a volume of air into the stomach through the NG tube. Absence of air escaping through the mucosa suggests that it remains intact. Recovery. Infant can be extubated in left lateral position once fully awake. Coming to the post-operative care, neonate is shifted after complete recovery to NICU. Strict vigilance monitoring is required by trained staff, especially for post-operative apnea, at least for 12 hours, and apnea monitoring can also be utilized for this purpose. Post-operative feeding regimens vary between centers. Some surgeons advocate a 2-hour nil by mouth. Early feeding from 4th post-operative has been shown to be of benefit. So coming to summary, it is a medical, not a pyloric stenosis, is a medical, not a surgical emergency. Treat the dehydration, hypokalemia, hypochloremia, and metabolic alkalosis before proceeding to a surgery. Stomach should be emptied with nasogastric tube before induction, and RI rapid sequence induction, ensuring good depth of anesthesia, and take care of postoperative apnea. Thank
Very
you.
good. Very good. You have nicely covered all the points, except one or two. You must first you correctly started with the problems with the neonatal anesthesia, and there started with thermogenesis, glucose control, What about the cardiovascular system? How does it differ from the older child or an adult? Actually,
So
not
that's what I
only as
started
you said,
asking, sir. The presence of the patent ductus.
not only that, the muscle mass is very much low in the neonates. So they are rate dependent cardiac output patients. Okay? So rate is very, very important. Any amount of even a small bradycardia will cause a very damaging cardiac output fall. And
Yes.
then if there is a sudden severe hypotension because of bradycardia, it may be very difficult to revive with the patient having a lot of electrolyte imbalance preoperatively. So correction of electrolyte imbalance is very, very important because even a minor bradycardia may result in total arrest. There is a terminology called flip-flop circulation. Have you heard of that? What is flip-flop circulation in a neonatal cardiovascular system?
No, sir.
Rao, Venkateswar Rao?
No, sir. No, sir.
You are not heard. Okay. See, normally, what is the circulation and when the baby is in utero, before delivery? How does the blood flow coming from the mother through the umbilical vein? Blood reaches the right atrium, then it goes to the right ventricle, and then when it is pumped into the pulmonary circulation, immediately the blood is diverted to the, because there is no lung function, so there is no point in pumping the blood into the pulmonary vasculature. So there is a communication to the aorta, which is called the ductus arteriosus. So the blood is diverted into that. But once the baby is born and the first breath is taken, the increase in the pulmonary oxygen level causes a closure of the ductus and blood starts flowing through the normal pulmonary vasculature to reach the left atrium and come to the left ventricle, and blood is delivered to the systemic circulation, isn't it? So
Yes,
in
sir.
the neonatal period, when you give anesthesia, there can be a reversal or open up of the ductus arteriosus, and the blood can start flowing directly from the pulmonary circulation into the systemic circulation through the aortic communication. Okay? So when it changes like that and then goes back to the original normal circulation through the left atrium, left ventricle, and aorta in a normal way after the post delivery, this changes can happen in between. It's called the flip-flop circulation. So if it goes through the intrauterine life type of circulation, what will happen? Blood will not
Hypo
go into the pulmonary circulation, and so there will be no
hypoxia.
oxygenation taking place, and patient may become hypoxemic. So
Yes.
that is a dangerous thing that we have to think of.
Yes.
Actually, as you said, pyloric stenosis babies come to the hospital with complaints little later, after 4 weeks or 6 weeks only, because they are persistently vomiting and start becoming little dehydrated and then become restless and all that. Then only the mothers bring the babies to the hospital. Very severe cases only are attended immediately, and I purposely gave it as a 5-day-old neonate because I thought it would be easy for you to read about neonatal anesthesia. The age of the baby is given in the neonatal period. So you have to mention something about that. And coming to the prevention of aspiration before induction of anesthesia, as you rightly said, you put a nasogastric tube, do what is called 4-quadrant aspiration. That is a very important step that you have to mention. Where first you put the patient in supine position, do an aspiration, then turn the baby to the right lateral position, again aspirate, then put the baby in full prone, then aspirate, then turn the baby to left lateral and then aspirate. So in all the 4 positions, you have to aspirate the NG tube, and that is called the 4-quadrant aspiration. And after doing the aspiration, you have to remove the NG tube. You should always remember that you should not keep the NG tube while you are trying to induce and intubate. As you rightly said, it should be a modified RSI. It's very difficult to identify the cricoid cartilage in a baby, and trying to give a pressure on the cricoid will completely occlude the trachea and make difficult intubation much more difficult. So it should not be applied, and you can gently ventilate without inflating the stomach by large volumes and improper position of the head and neck. That is a very important step that all of us should learn how to ventilate neonate without inflating the stomach. If inflation occurs, it will not only cause a regurgitation, but also it will impair the ventilation later on. Because the distended stomach will not allow the diaphragm to move down, patient will definitely go into respiratory distress. And so all the other points I think you have covered well.
Sir, I just wanted him to say, he kept saying twice, he kept saying that it is more of a, I mean, it is a medical emergency and not a surgical emergency. I think he must say it is more of a medical emergency
more of a, yes.
than a surgical emergency.
Yeah. You
Yeah.
must, that is very
More-
there is no immediate urgency to operate, but
Yes, sir.
to stabilize the patient and correct all the defects, electrolyte defects, dehydration and all that, and then try to release it as early as possible. And another point you can mention about is the length of the endotracheal tube that to be introduced into the trachea. Have you heard of Tolkien's formula?
Yes, sir.
What is that?
ಅದು into 3, sir. 3 tube will fixed at 3 tube will fixed at 9 centimeters. 7, 8, 9, 1 to 3.
1 to
3
3.
tube.
Yeah. The baby is 1 kg weight. You can pass
1 kg.
up to 7 centimeters at the lip level. If the baby is 2 kg, you can go up to 8 centimeters. If the baby is 3 kg, you can go up to 9 centimeters. So another method of modification is weight of the baby plus 6 should be the length of the tube in centimeters should be seen at the lip level. They don't have the teeth. You don't mention about inches or level or anything. So at the lip level, you have to remember that too much enthusiastic introduction of the tube may go into which bronchus it will go.
Sir? Right, sir.
This is a common question in the examination. The neonate and the infants less than 1 year, you can go to right or left because
Or left. No angulation.
it is not to
No,
the.
there is angulation. No,
No
there is
angulation.
angulation. What is the, no, there is angulation. How can there not be angulation? There is angulation. What is the
They are
angulation?
equal angulation. Okay?
Equal, both sides.
Yeah. It is not where when they become 3 years old, it becomes like an adult where the right takes off in line with the trachea. So right endobronchial intubation will be more
25 and 40.
So less than that, it will be equal 25 to 25. So it can go to right or left. So don't make a mistake in the exam. It can go to any side. It is not like an adult or an older child where it will go only to the right side. Right, share the screen.
Yes, sir. Please, sir.
So this operation is also called pyloromyotomy. Sorry, pyloromyotomy. Any other operation done similar to this? Where you just cut the muscles and try to expose the mucosa, keep it intact. Just by way of your surgery knowledge, what you have read in your surgery.
J-plasty.
Which other surgery is done in similar fashion, but at again in the gastrointestinal tract at a higher level?
Have you heard of Heller's operation?
Heller's
Cardia.
Heller's myotomy.
There also you just cut the muscles alone, leaving the mucosa intact. So achalasia cardia, Heller's operation is almost similar to this surgery. Okay. So first, in this sort of case scenarios, I thought always you can give the challenges that you faced. So in this case, the first challenge is a challenge pertaining to neonatal anesthesia. Second is the electrolyte and acid-base derangement due to the pyloric obstruction. And the third is the dehydration due to repeated vomiting. So pertaining to neonatal anesthesia, what are the issues of concern? First is thermoregulation, glucose management, positioning, which all you mentioned, intubation and airway management, respiratory system and metabolic oxygen requirement, and cardiovascular system. That also is a very important thing. Circulating blood volume and blood loss is another important part because they are very sensitive to hypovolemia. And pharmacology and drug metabolism, the neonates is totally different because the liver enzymes are not well developed and renal function is also not mature enough. So you have to discuss all these things. So coming to thermoregulations, they have less brown fat, so less thermogenesis. They are so small that proportionately larger area of the skin gets exposed, so heat loss will be more. And general anesthesia affects the thermoregulation at the hypothalamic level. That happens in everybody, but here it will be more pronounced. And it is common for core temperature to drop 1 to 2 degrees Celsius in the first hour of anesthesia. Immediately you can say what are all the remedial measures you can think of also along with this. To prevent heat loss in neonates, it is common to have the OT temperature about 78 to 80 degrees Fahrenheit before the patient comes itself. And also it is use body forced air warmers between 38 to 43 degrees Celsius, and warming lights also should be there. And you can cover the head, it's very important. In the neonate, there is a large head, so evaporation and heat loss happens through the scalp also. So hat should be used to cover the head, and warm humidification of the ventilator circuit will also help in keeping the babies warm. And all fluids in the surgical field they use for washing or cleaning, and all blood products all to be warmed with a warmer, and minimal exposure during transport from OR to with the hat and transport warmer also is very common. And isolates should be plugged and kept in warm in preparation for transport. Any idea what is this isolates are? Have you ever seen this isolates? Those who have had an opportunity to work in the pediatric unit. So this is the isolate. So this is the something, a glass cage where can be warmed with electrical equipment. So this is called the isolate. So newborn babies have to be transported only in this. And coming to the glucose management, here they are at the risk of hypoglycemia because they have impaired glycogenolysis and gluconeogenesis. Both are defective or not well developed. Neonates have decreased glycogen store also, and if you keep them NPO, it will aggravate the hypoglycemia. So common IV fluids to correct the hypoglycemia, you should use 10% dextrose in water with 0.2% normal saline, sodium chloride. And positioning, neonates have thin skin and relatively excessive fat stores. So you have to keep them properly positioned, and checking them after draping will be very difficult. And they have very flexible and soft skull also. So you have to take care that skull skin is not, that is scalp skin is not under pressure. And pay close attention to placing the head on a gel horseshoe. All of you would have seen the head support like this. Various sizes it's available. It's very soft and you can just support the head and the groove that neck should be placed in that. And coming to the intubation and airway management, intubating neonates, one must know the anatomy because of the large head, floppy epiglottis, and more capillary position of the larynx. Intubation may be much more difficult compared to adult and easier to intubate in the neutral or a slightly flexed position rather than going in for the sniffing position that we use for adult. And so this is how you adopt that position by giving a roll under the shoulders and then see the angle at which the mask is held, this arrow that it goes. So this neck and the mask should be parallel. If you do that, then your this finger is just gently lifting the mandible. So if both these things are in parallel line, then inflation will occur only of the inflation of the chest and not the stomach. So this is a question all of you must be aware of. And Ocean created a 789 rule, which I just now told. So for 1 kg neonate, you just tape it at 7 centimeter at the gums. 2 kg you can tape it at 8 centimeters, 3, 9. Another method is to calculate is 6 plus weight in kg. Coming to the respiratory system and metabolic oxygen requirements, neonates desaturate quickly, all the reasons Rao mentioned. Because the closing pressure of neonatal airway is very low and occurs quickly. FRC is also very low. That is another important point that we all of you have to remember. And consumption of oxygen or oxygen requirement also is very high. That point also I think we mentioned. And coming to the cardiovascular system, myocardium is less compliant than adult myocardium, making cardiac output rate dependent. And neonatal vasoconstriction is also less responsive to hemorrhage. 10% reduction in blood volume, causing 15 to 30% decrease in mean arterial pressure. So volume status is very important because neonates cannot increase their SVR and maintain the blood pressure. So neonates do not tolerate blood loss and have decreased compensatory reaction or response to blood loss. And to this, you can add the flip-flop method of circulation, which can take place in the first few days of birth. And circulating blood volume, neonates have a blood volume of 90 ml per kg. So it is often imperative to calculate the maximum allowable blood loss for neonates based on their starting hemoglobin and the lowest hemoglobin that can be tolerated, which is usually 8 grams per deciliter. Sorry, there's a mistake in that. And allowable blood loss is calculated by estimated blood volume multiplied by the initial hemoglobin plus final hemoglobin, that is minus final hemoglobin, whole thing divided by the initial hemoglobin. So if by using this formula, you can calculate the allowable blood loss, and most neonates can lose only about 50 to 75 ml of blood before considering a transfusion of packed red blood cells. This is about 20% of their circulating blood volume. And if you wait for the blood to reach the suction canister during neonatal surgery, it will be too late because it takes at least 50 ml of blood to reach from the field, operating field to the suction canister. So even before the blood reaches the suction canister, you must try to assess the blood loss. And in neonates, you have to replace blood with blood only. You cannot compensate with a crystalloid or a colloid. So you must have adequate stock of factor red blood cell. Of course, the volume required is very, very low, and but you must be very careful in this happening. But this surgery, pyloric stenosis, in experienced hands, hardly causes about 15 to 20 ml of blood loss and not more than that. And coming to pharmacology and drug metabolism, renal and liver maturation happens around 6 months of age, and so all drugs to be used with caution. To safely anesthetize the neonate, important plan is to plan the setup, obtain any necessary special equipment in the operating room, and decide on weight-based and appropriate anesthetic drug, and make a plan to keep the neonate warm, and hang dextrose containing fluids ready to correct any hypoglycemia. And also one should make an appropriate plan and backup plan for intubation, and position the baby very carefully, calculate the maximum allowable blood loss. This point I think you have to include in your answer, which was missing. And clear communication between the anesthesia and surgical team is the key and will help guide the neonatal anesthetic plans. Now coming to the second challenge in this, the electrolyte and acid-base derangement due to pyloric obstruction. Vomiting is the principal symptom, and it is described as a projectile vomiting. So when the child vomits, the contents will be splashed at to a distance. It will not be just spilling on the body itself. It will be like a bloodshot. It will come projectile outside. And the vomitus in pyloric stenosis is mainly gastric content, because it is not going or coming from the duodenum. It will not contain any bile. It will be a pure gastric fluid, and they are rich in hydrogen and chloride, and also sodium and potassium along with water, and which causes hypokalemic, hypochloremic metabolic alkalosis, because all the acid is lost. And the body will try to prevent development of alkalosis by bicarbonate excretion in the urine to compensate for the alkalosis. But so initially the urine will be alkaline in nature, but eventually what happens, to maintain plasma volume becomes more important. So that becomes a priority. Then kidney starts excreting hydrogen ions in exchange of sodium and water to maintain water balance, resulting in paradoxical production of acid urine despite the metabolic alkalosis. This point also has to be mentioned in your answer. This is a very peculiar situation for this pyloric stenosis, and this description, paradoxical production of acid urine despite metabolic alkalosis, also should be included in your answer. And medullary chemoreceptors in the brainstem respond to changes in the hydrogen ion concentration, with an increase in the hydrogen ion concentration stimulating ventilation. This is the normal physiology. Our ventilatory drive is mainly because of the CO2 mixing with the CSF, getting broken down by carbonic hydrate, producing hydrogen ions. An increase in the arterial pressure, partial pressure of carbon dioxide results in increased hydrogen ion concentration in the CSF, and stimulates the respiration. Whereas in metabolic alkalosis, respiratory depression will happen because of lesser amount of hydrogen that is available, and apnea is very common. So this will be aggravated by CNS depressant effect of general anesthesia. Therefore, to minimize the risk of postoperative apnea, alkalosis must be corrected to the maximum extent possible before surgery. This is a very important point. And equilibration of CSF pH with plasma takes several hours. So it is better that you try to correct it as early as possible. And it is possible that plasma pH may be returned to normal while the CSF pH remains increased, thereby exerting a respiratory depressant effect. So this point will have to be remembered well. So as it is, premature babies will have apnea of prematurity, which is very common. But if it is a full-term baby, still the apnea possibility is there because of the alkalosis. Then the dehydration due to vomiting, it is because of the water loss causes dehydration, and this will result in the secretion of aldosterone. So aldosterone will cause reabsorption of sodium in exchange of potassium. That is the reason for the worsening of hypokalemia. And the degree of dehydration must be calculated correctly and corrected slowly, and unless the cardiovascular instability or the patient is in hypovolemic shock. And pyloric stenosis is a medical, not a surgical emergency, and patients safely wait for surgery while they are rehydrated and their electrolyte abnormalities are and alkalosis are corrected. Coming to the surgery part of it, it's a surgery described by Ramstedt in 1912, which he mentioned, and laparoscopic and open methods are available for that. Laparoscopy is a later development. So laparoscopic pyloromyotomy is associated with less pain as with any other laparoscopic procedures, and the duration of surgery and anesthesia in experienced hands is similar for both the techniques, whether it is open or laparoscopy. Now, pre-anesthetic optimization, correct electrolyte derangement and dehydration, with initial bolus of isotonic crystalloid. That is, you can give normal saline or regular lactate with potassium, 20 ml per kg, and patient is kept nil by mouth. Maintenance fluid of 0.45% saline with glucose 5% can be given at the rate of 150 ml per kg per day. So for the entire day, the dosing requirement is only 150 ml. So as he rightly mentioned, the diuretic is very, very important to prevent overhydration. And the gastric outlet obstruction associated with the pyloric stenosis prevents stomach emptying, and there is a risk of aspiration when general anesthesia is induced. So these patients sometimes, as he said, NG tube is inserted in the wall itself to prevent vomiting, and periodic aspirations are done. If this is the method followed in that particular unit, surgical unit, then that fluid also has to be taken into account while you correctly replace the fluid. So for those who arrive with the NG tube in place, maintain an index of suspicion. When there is no aspiration, you suspect that it may be blocked or malpositioned. And check the depth of insertion. The NG tube should be at least 20 centimeters inside. And check the fluid balance chart, that documenting regular aspiration. So how much of stomach content aspirated, or that also should be included in the output chart. Intake output should include the aspirate also. If insufflate a small amount of air, if you think the tube may be blocked, as we all know, that's how to clear that, and then try aspiration. If at all there is any doubt, remove the NG tube and replace it with the orogastric tube. So no, don't go by the nasal route, you can go by the orogastric tube. Emptying the stomach may be performed by rotating the infant from supine left lateral, prone and right lateral, or right lateral, prone, left lateral, any way you like, which is called the 4-quadrant aspiration. So before induction on the table, before you induce anesthesia, this 4-quadrant aspiration is a very important step. And ultrasound assessment of gastric contents has been studied, and it's demonstrating that a qualitative assessment of stomach contents can be made easily, quickly and easily before induction of anesthesia. And the chemical findings, once the alkalosis has been corrected, should be within the following range, that is pH should be within normal range, 7.3 to 7.45, and chloride should be 95 to 112, base excess should be 4 to 2.5, and potassium should be 3.5 to 5.5, which is like any normal value. So you aim for that. Coming to the anesthetic management, rapid sequence induction and intubation is performed, but should not be applied like what you do in adults by giving the cricoid pressure. That is a very important step you have to remember. So you modify it by gently ventilating the patient after you give the induction agent and relaxant. So application of cricoid pressure may be difficult, and identifying the cricoid ring also is very, very difficult. So cricoid pressure is therefore best avoided. Gentle bag mask ventilation is required, and tracheal tube intubation before tracheal tube intubation to prevent hypoxia and bradycardia. And choice of anesthetic induction can be either inhalation method or an induction, IV induction. When you want to do inhalation technique, induction should take place in the operating room. This is mainly because the Western books will say there is a induction room and then a OT operating table will be separate. So usually patients are induced anesthesia, especially in the UK. They have this habit of anesthesia induction room separately. The patient will be shifted. Whereas in our country, we do everything on the table where we are going to operate. So this will not apply to our patients. And after evacuation of gastric contents, if necessary, do a gastric ultrasound also. And active warming and standard monitoring is established. IV cannula, if it is already present, you flush it and make sure it is patent and working. And you can give sevoflurane by inhalation in oxygen 4 to 6% with oxygen 60 liters per minute and Jackson Rees TPs with the spontaneous respiration. So a good face mask with a properly applied, tightly applied face mask will be sufficient to make the patient breathe comfortably, and you can observe the spontaneous respiration by looking at the reservoir bag. Once infant has lost consciousness, you can give atracurium 0.5 milligram per kg administered, and when the patient becomes apneic, you can take over the ventilation and gently do a mask ventilation. Avoid vigorous bag mask because you will not only occlude the upper airway but also inflate the stomach. So this technique is mainly only for experienced persons. So for theoretical sake, you can describe that, but in practice, it is better not ideal technique for the beginner. So experienced people can still do that, and but you have to write this in the exam because this is one of the accepted methods of induction. And you must allow sufficient time for the neuromuscular block to take place. Hurried laryngoscopy may cause the child to buck and vomit. And so laryngoscopy is performed and the infant's trachea is intubated with a free-sized microcuff endotracheal tube. So this is the newer thing. Earlier we never had this microcuff endotracheal tube. We had only plain tube. And the teaching also was that you should use only a plain tube in neonates because of the cricoid region being narrow. Using a cuff tube will cause edema when you extubate. All that is now being disproved, and they advocate microcuff tube. And for those who have not seen that, this is the microcuff tube. You can see how small that cuff is. It is not extending to a large extent, and the tip is very close to the cuff. And IV induction technique, we perform it either with propofol or ketamine, 3 milligram and 2 milligram per kg. And neuromuscular block can be achieved with succinylcholine or atracurium or rocuronium. There are three choices. And Saxa, you give 2 mg, atracurium, you give 0.5 mg, rocuronium, 0.3 to 0.7 mg per kg. And use of microcuff tracheal tube may be advantageous because they are currently available for children weighing more than 3 kg and reduce the time to isolate the lower airway and also prevent the necessary for changing the tube. For example, you think it will be holding only a 2.5. You put it and then the bag is not filling, there's a lot of leak. Then you have to remove the 2.5 and put a 3 size tube. So all that exchanging might not happen if you have a microcuff tube. So two advantages is it prevents soiling by properly isolating the lower airway and prevents the need for changing the tracheal tube. And the anesthesia is maintained with sevoflurane or desflurane in a mixture of oxygen and air. Don't use nitrous oxide because it can expand the gases. and isoflurane is associated with more episodes of postoperative apnea. So if you have only isoflurane available, it's better not to use it. Rather than you can give a small dose of very small dose of midazolam and avoid the usage of any inhalation agent at all. But best will be to go for CO or desflurane. Analgesia may be provided by ultrasound guided rectus sheath block. This is a very useful technique, or a tab block, or local infiltration as mentioned. And rectus sheath block is very useful for circumumbilical incision. Some surgeons, instead of making a transverse incision in the epigastric region, they make what is called a circumumbilical incision and then go through that. And tab block is very useful in laparoscopic technique because you can block both the sides. It gives a better pain relief. And bilateral rectus sheath blocks reduce the intraoperative end-tidal vapor concentration also. So the requirement of inhalation agent, if the block is given at the beginning of the surgery itself, it will reduce the need for analgesic as well as the inhalation agents. And paracetamol is the only safe analgesic that is required. Opioids can be avoided as much as possible because of they are very sensitive to opioids, and also the apnea is very common. So IV paracetamol is the only drug which is licensed for use in neonates more than 32 weeks post-menstrual age or post-conceptual age. But care must be taken to ensure that the correct dose is given. Don't overdose because paracetamol, as you all know, is metabolized only in the liver. So you have to be very watchful. And suitable doses for neonates are 7.5 to 15 milligram per kg. And rectal paracetamol up to 40 milligram is an alternative. And there is rarely any need for opioid analgesics. And if at all you want to give a very small dose of fentanyl. Regular paracetamol is usually sufficient for post-op analgesia also. And laparoscopic approach is usually well tolerated, but intra-abdominal pressure should be kept less than or equal to 10 millimeter of mercury. This is another important point in this particular technique. Ventilator adjustments are likely to be required to maintain adequate minute ventilation, and absorption of CO2 across peritoneum may lead to hypercapnia. So when laparoscopy is being done, you must be very careful about hypercarbia also. Towards the end of the operation, the surgeon may ask to inflate volume of air to see whether the mucosa is breached. If they have made a leak in the mucosa, you will see the air bubble coming out through that. But if it is intact, it will not happen, and the air will flow through the pylorus into the duodenum very easily. So this is the one test that surgeon may request you. So you have to insufflate air through the orogastric or nasogastric tube and make sure that the mucosa is intact. And the absence of air escaping through the mucosa suggests that it's remaining intact. And visualization of air passage in the duodenum also can be seen. And then you can aspirate the NG tube. Once the surgery is successful with an intact mucosa, you can aspirate the NG tube and remove it before the patient is woken up. Then the infant is extubated in the left lateral position once fully awake, and there should be adequate spontaneous respiration, and child should be obviously awake and moving vigorously. If you have used atracurium, you may have to reverse it with neostigmine also. Post-op care, the patient should be observed in the post-operative recovery area until fully awake. Pulse oximetry and apnea monitoring for 12 hours is necessary. If there has been no apnea, you can remove that monitor after 12 hours. But if there has been even one episode, you have to continue it at least for 24 hours. And as mentioned, oral can be started 2 hours after the procedure, but some centers may start it late also. The first feed is usually water or electrolyte solution, followed by volumes of milk feeds on demand. So that is the presentation I would like to start.